Hello, my presentation will be completely in line with Paul's presentation. I am Bruno Falissard. I am a professor of public health in Paris-Saclay University and child and adolescent psychiatrist. I have no conflict of interest for this presentation. I will first begin by the question of planning child and adolescent psychiatric services in high-income countries. In high-income countries, in most countries on the planet, you have a liberal economy with a market, and so there is an equilibrium between supply and demand. And demand in health is likely to be associated with needs. And this was the presentation of Paul. Needs should rely on objective data. These objective data should be related to epidemiology. And so we have to compute the prevalence and the incidence of many mental disorders in child and adolescent, and to put that in relation with a certain number of psychiatrists. In fact, it is a little bit more tricky, and this has been emphasized by Spitzer, a well-known adult psychiatrist American, in 1998 in a paper of the Archive of General Psychiatry that was entitled Diagnoses and need for treatments are not the same. I would say epidemiological diagnoses and need for treatment are not the same. When you have an epidemiological diagnosis, in fact, you have to consider that this is a very abstract construct. Why? Because there is a real problem in epidemiology to have the level of clinical relevance of the disorder you estimate. And you know that to say that there is a disorder, you need to show that there is a certain level of impairment, of disability, and this is the reason why Paul mentioned that there are mild, moderate, and severe disorder. There is a lot of subjectivity in that, and according, if you take severe or moderate disorder, prevalence can vary a lot. Some authors have proposed that a real disorder, a true disorder, should be a disorder where a patient has seen a professional, where a patient has taken a treatment. But here there is some kind of tautology. If you define needs by people going to see a professional, there is a vicious circle and it does not work. Another point is that clinicians are often biased, and this is not proper to child and adolescent psychiatry, but we are very sensitive to that. We see patients everywhere. And because we see patients everywhere, politicians are afraid that the demand that will come from us will be very, very important. And so, to sum up with this slide, there is a real problem with an objective definition of needs in child and adolescent psychiatry, and we have to acknowledge that it is difficult to say what is a true disorder. And so we are quite in a situation where there is mission impossible, but mission is necessary anyway. And so how to do that? How to plan child and adolescent psychiatric services? I think there are 3 points that should be pointed. First, we have to do some health economic modeling. We lack a lot health economic studies in child and adolescent psychiatry, and because of that, we are not assertive enough in our relationship with politicians. We have to show that our treatments are cost efficient, that is, the amount of money in dollars or euros are indeed in a good position when we compare to cancer or AIDS in terms of quality adjusted life years that are gained for our treatment. This is cost per quality. This is a health economic concept that is very important for politicians, and we do lack data about that, and this is a shame because we are highly competitive and often we don't realize that money is important. So first point, health economic modeling. Second point, we have to understand that to plan services, there are 2 aspects. The first one, bottom up, that is, what are the needs from the population? And not only objective needs, but also subjective needs. You see, it is something that happens frequently in country where when the supply of child and adolescent psychiatry increase, the demand increase at the same time. People become aware that their children need some treatment, and because of that, when supply augment, demand augment, and so this is very difficult to find some model. Traditional economic modeling can be difficult for that, and instead of objective needs, we have also to consider subjective needs according to culture, to country. The way parents consider the needs for their children can vary far beyond the objective value of prevalence of mental disorder. So there is a bottom-up perspective, and there is of course a top-down perspective with prevalence first, and that put in line with the amount of money that there is in a society, in a country, with the amount of money that is available for medicine in general, and child and adolescent psychiatry within medicine in general. For instance, we know that most countries will not spend more than 10% of their gross domestic product in medicine. And so, because of that, we will be obliged to determine the amount of money available for child and adolescent psychiatry. This was the second point. The third point is how to structure the healthcare system. In most countries, there is a vertical paradigm, a hierarchical organization of care with, we are going to see that in more detail, with primary care, first level, second level, tertiary level of specialized care. And of course, it makes sense, but we have to realize that in addition to vertical healthcare, there is also a horizontal organization. Because child and adolescent psychiatry has to be articulated with child welfare, special education, disability. Names can be different across country, and as we have seen that with the presentation of Nick and Valsama, prevention programs are also very important. But is it exactly the same to plan prevention program and to plan a healthcare system? My feeling is that it is not the same. We have to split what is related to healthcare system and what is related to disability management, special education, etc., and prevention program. Why? Because in medicine we have physicians, and in many countries, in particular countries where the Hippocrates oath is important, physicians have some kind of authority and some kind of legitimacy to do things. And this legitimacy exists within the healthcare system, not outside. This is the first point. The second point, which is even more important, is about money. Money for medical care in many countries come from health insurance. Why money for special education, social program and prevention come from the social budget, and these two budgets are completely different in many countries. So we have to think together psychiatric care and special education social program, what I call the gray zone. We have to think them together, but we have to think them also splitted because of the money. Concerning the medical part, as I said, there is a hierarchy between primary care, first line specialized care, second line, and third line very specialized care. This is accepted in most countries. The problem is the percentage here. How many patients, how many children and adolescents will come from one line to the other line, and this has to be estimated according to the money and the resources that are available in the country. Another point is that nowadays, more and more, we have e-health technologies to help to implement mental health resource. And this is very interesting because these e-health technology are very cost effective. Sometimes a little bit effective, but always they cost quite nothing. They are very cheap. And so their cost effectiveness balance is very interesting. And because our patients are young, they are very used to use this kind of smartphone and tablets. And so the implementation of e-health resource can be very useful for child and adolescent mental health. The other point is about productivity. which professional for which care? This is a question that we have to ask, because psychiatrists cost a lot. Psychologists cost too also. But nurse cost less. Social worker cost less in many countries. And perhaps sometime social worker can do the job better than psychiatrists. And we have to determine in which situation which professional will be the most effective. In low and middle income country, the situation is obviously many times different. For instance, in India, you have more than 200 million of children and adolescents, and you have less than 100 psychiatrists. And so, obviously, a very well-designed child and adolescent psychiatric healthcare system cannot be conceptualized in the same way in India and in Australia. Because even if in India there is a strong voluntary to train more and more psychiatrists, there are a so important number of children that even in 50 years there will be a lack of psychiatrists. And so, in this situation, there is a need to be very careful. To be very careful because, of course, we need to use evidence-based treatment. We need that. But we have to be careful because in many times, this treatment will not be sustainable. They have been designed in Occidental country, in high-income country. And so, if they are not sustainable in a low or middle-income country, this treatment will not be acceptable. And sometimes, even, they are not culturally transposable. Because of the culture and because of the way psychologists, psychotherapists are trained. And there is also the question of screening. Screening is a major issue for the future of child and adolescent psychiatry. We have seen that in the previous presentation. But screening is ethical only if you can offer treatment for the patients that have been screened. And a third point about low and middle income country, we should not say that they are low resource country. This is what Olayinka Obigdobun say. She is the head of the Nigerian child and adolescent psychiatric community. These countries are different resource country. In low and middle income country, you can have resource that does not exist in high income country. These resources come from cultural specificity. And so to organize the healthcare system in this situation, we have to understand cultural specificities. The other point is we have to implement mental health literacy and training of a teacher, nurse, so that you have to take resource, to use resources where they are. And training can come nowadays from resources that are free and online. For instance, the IACAPAP provide many of these resources, the e-textbooks, the Juray e-textbook that is very famous. There is a MOOC that is free, that has trained already more than 20,000 people, and the ICAM project. WHO also has proposed the MHGAP to train mental health professionals. We are going to come back to that. And of course, e-health will be even more important for low and middle income countries. And the notion of supervision is important because the job of psychiatrists in this country will be most of the time to supervise teams. A little, some words about the WMHCAP that are pro and cons. The WMHCAP, this is a textbook where you have algorithms that are provided to nurse, GP, to see when they have a patient in front of them, what are the symptoms and what could be the treatment according to the symptoms. This is very well done, obviously, but the introduction of this textbook of this WMHCAP is a little bit problematic. It is the past president of WHO that say, there is a widely shared but mistaken idea that improvement in mental health requires sophisticated and expensive technologies and highly specialized staff. The reality is that most of the mental, neurological and substance use conditions that result in high morbidity and mortality can be managed by non-specialist healthcare providers. In a way, this is true. In a way, this is true, and this is interesting to say that because there is the idea that we can train nurse and GP to do the job. But imagine you have a politician that sees that in Australia, in Great Britain, in France, in the US. They will say there is no need to pay expensive psychiatrists. We don't need psychiatrists anymore. In fact, this is true, but this is false. To treat mental and neurological and substance use condition, you need always a certain amount of highly specialized healthcare providers. And so we have to have in mind that, of course, mental health literature is really important, but on the other side, we have to train highly specialized professionals that are psychologists or psychiatrists. This is my last slide. To conclude, evidence-based medicine is good, and evidence-based medicine has been a revolution in medicine and in child and adolescent psychiatry in particular. But transferability, sustainability are mandatory. There is now something that is called implementation research that is as important as evidence-based medicine. A treatment that is not sustainable, even if it is evidence-based, is not a good treatment. In child and adolescent psychiatry, we need health economic modeling. This is as important as evidence-based medicine, because if we show that we are cost-effective, we will have money to spend to our patient. We have to understand that the level of supply corresponds to needs, but this equation, the relation between supply and needs, is highly flexible because the notion of prevalence is a very complex notion. We have also to clarify the relationship that exists between health insurance and social budget in funding child and adolescent psychiatric services. In many countries, this is not clear. In many countries, when you want to say how much money this country spend for child and adolescent mental health services, this is even not possible because of this split. Of course, mental health literacy and training are crucial for the next decades, and the e-health tools are also likely to be a revolution because of the age of our patients and the fact that they are completely ready to use these tools. Finally, in low and middle income countries, there is the question of local training, and there is a question of cultural specificity and local resource, and this must enlighten all of us to understand that cultural specificities exist in all countries, whether they are low or middle income or high income country. I thank you for your attention, and I think we are now open to answer to your question with the chat.